On the occasion of International Women's Day, NewsX wishes to highlight the importance of fertility awareness and its fundamental importance to a woman's health. In order to take this conversation forward, we are being joined today by a very special panel. Yes, today we have with us leading gynecologists from the Federation of Obstetric and Gynecological Societies of India, FOGSI. FOGSI is a team of 43,000 members across 277 societies. They have in fact delivered 12,000 research papers pertaining to fertility. Our panelists today have been in practice for more than 2 decades and will help us seek answers to some very important questions on fertility, its treatment, IVF and much more. So let me quickly introduce my guest today, Dr. Hrishikesh Pai, past President FOGSI, is joining us live. Dr. Rishma Pai, past President FOGSI, is also live with us. Dr. Nandita Pal Shetkar, past President FOGSI, is live with us as well. Dr. Jaydeep and Dr, President FOGSI, joins us live. Dr. Sunita Tandulwat-Vadkar, President-elect FOGSI, is also live with us today. Welcome all of you and thank you so much for being with us today. Let me begin with you first, Dr. Rishma Pai, on how you would define infertility. Can you explain also the common causes of infertility in men and women? Dr. Rishma.
Hello to all of you. Really happy to be here today discussing this extremely important subject of infertility, which, as you know today, is affecting 17.5% of young couples who are in the reproductive age group. So almost 1 in 6 couples suffer from infertility at some stage of their lives. And infertility really is defined now as a disease of the male or female reproductive system, which is really inability to achieve a pregnancy after 12 months of more of trying without contraceptive use. So if for 12 months of trying you haven't conceived, you can be labeled as an infertility person. It can be primary infertility if you've never had a baby, or secondary infertility if you had one pregnancy or miscarriage and then are unable to conceive. So there are many causes of infertility, and sometimes it is unexplained. You cannot find a reason at all. So commonly, it may be the female who has many different factors causing infertility. For example, a tubal factor where her fallopian tubes are blocked due to an infection or maybe tuberculosis in the past. There could be an ovarian factor where a patient has had cysts in the past, she's had a surgery on the ovaries, or she's going into early decline of the function of the ovaries. She could have problems like PCOS, hormonal problems, polycystic ovarian syndrome, severe thyroid or prolactin disorders, which affect fertility. In our country, tuberculosis is a common cause as well. Also, people don't realize this, but in many cases, almost 40 to 50%, the man may be responsible for infertility. So if we see a low sperm count or poor motility of the sperms, that is a cause, and that may be due to infections, again, tuberculosis. He may be a smoker, obesity can contribute to that, some drugs can contribute to that. Sometimes we see completely absent sperm, zero sperms, what we call azoospermia. And this could be because of early testicular failure, because of some immune causes, or it could be absence from birth of the tubes which bring out the sperm, mumps in childhood, undescended testes in childhood. So essentially, there are many reasons behind infertility. And the first step is really to find out the cause, and then accordingly we can start to treat.
Right. Dr. Jaydeep and I'd like you to come in here on, how do you investigate the couple then suffering from infertility? Obviously, it's something that has to be diagnosed first. How do you investigate then the couple further?
Yeah, thank you. Thank you, Rishma, for that wonderful way of explaining the reasons, because that's a nice segue into how we investigate. I usually like to tell patients that at its very basic, the reasons for infertility could be attributed to either sperms, eggs, or the female organs, which are the uterus, the tubes, and the ovaries, and the extrinsic factors which govern the production of eggs. And that's why the approach to investigations takes a similar kind of a format, wherein you evaluate the sperm with a simple semen analysis. However, when the semen analysis is done, it's quite vital to remember that a single semen analysis may not always reveal the entire picture. And a diagnosis of male infertility should ideally not be made on the basis of a single semen analysis. It's always better to double check and make sure that there is indeed a male infertility issue there. The second is checking the eggs. And this is done by a composite of various factors. Age, for example, is extremely crucial when it comes to determining whether there is a good ovarian reserve or not. And this is supplemented by the use of ultrasound and blood tests, for example, serum AMH. And if there is a history of irregular periods or there's a history of a patient not having periods, then supplementary blood tests are used to achieve the diagnosis. And lastly, for the female genital organs, ultrasound is the most basic investigation along with an examination of the genital tract by the gynecologist. And of course, ultrasound does not necessarily reveal whether the tubes are patent or not. And after some basic treatment, or if there's been a long time of trying, then you could investigate the tubes with the use of either an X-ray, which is known as an HSG, or a sonosalpingography. And once you have done all these basic tests, you then arrive at a diagnosis. It is, however, crucial to remember that sometimes, despite all investigations, you may not be able to make a diagnosis. And there is a certain group of patients, and this is called idiopathic infertility. This group of patients typically is very frustrated because they say, Doctor Saab, सब कुछ normal बोल रहे हो, लेकिन हो क्यों नहीं रहा है? And I always tell them that look at it the other way. अगर सब कुछ normal है, तो definitely होगा. And there are various kind of treatment approaches depending on what your diagnosis is. It's crucial, of course, to remember the difference and walk the thin line between hope and reality when you achieve a diagnosis.
Right. Dr. Rishikesh Pai, what is the general approach then for treating such an infertile couple? So obviously the diagnosis aspect we've heard now from Dr. Jaydeep, but moving forward, how do we go about treating such a infertile couple?
So, a lot of time people will phone me and say, Doctor, I want to do surrogacy or I want to do IVF. So that's not the actual treatment, it's the last step. So, as Dr. Jaydeep and Dr. Rishma has nicely told you the causes and how you investigate. Now, if suppose there's a male, generally there may be a little low count, you will just give them some medications to boost their count up. If there's some swelling, it's called varicocele. You can ligate it with, nowadays we can do it by laparoscopy or microscope as well. So we try to boost the male, and then of course we look at the female. Most of the time there's no problem. We normally would test the tubes, try to find out whether tubes are open or not, and that's done by a simple test called HSG. And if sometimes some people may have large tumors of the uterus called fibroids, or the uterus may be swollen called adenomyosis, or there may be some big ovarian swelling called endometriosis. Those we tackle by laparoscopy and hysteroscopy. So nowadays, in the olden days, we used to do the intervention a lot, but nowadays we are more selective in our intervention. And after that, most of the time, suppose they are obese, we would try to bring the weight down, stop the smoking, alcohol, with all these things. And then doing timed intercourse means we track the ovulation, and when the ovulation is there, we tell them to have sex, and most of them become pregnant. If they don't, then we go to another new technique, which is of course now old, which is called intrauterine insemination, where we take the husband's sperm, process it, and the best quality sperms are put into the cavity of the uterus. It's called IUI, intrauterine insemination. And that is done at the time when the eggs come out. So if it's this around 10, 20% people, 30% in 2-3 attempts of IVF, they get pregnant. If they still don't become pregnant, then we go to the next step, and that is called IVF. We take the eggs out, take the sperm, make the embryos outside in the incubator and put them back. So, and if there's a severe male count, we would do a different type of IVF called intracytoplasmic sperm injection. So basically, we keep on escalating the treatment, just like, I always give them the parallel of a cardiac surgeon. If a cardiac surgeon is not going to directly do a bypass, he will give you treatment, he'll put your weight loss, he will give you medication, then he'll do an angiography, he'll do angioplasty, and then ultimately go for a bypass. So I always say bypass and IVF are equivalent. So That's the last step. So normally 70% will achieve pregnancy with simple methods till IUI. Some 20-30% will need IVF, that is in vitro fertilization.
Right. Dr. Sunita, come in here. Dr. Sunita Tandulvatkar, on the IVF process. What exactly is IVF? Help define it for our viewers. Can you explain this process a bit more in detail?
Thank you. Thank you for this question, and hello to all. Now, what is IVF? Rishikesh has explained just in one line. IVF, as the name suggests, it's a in vitro fertilization. That is, fertilization of the gametes is happening outside the body, in the laboratory, in the incubator. So what we do in this, if you are fertilizing eggs and sperm, we need both these gametes to be taken out from respective the female partner and the male partner. So we typically, a lady usually produces 1 egg every month, while these eggs not necessarily may be healthy. We need to have more number of eggs. Now, usually the science is there are 8, 15 or so number of follicles they grow depending upon your age and AMH every month, but only 1 egg come out of this. Here in IVF, we allow all the eggs to grow, so they need injections to be given. More or less, they are 10 days plus minus 1-2 days. So all these follicles who are harboring these eggs, they grow together, and when they reach to the stage where they will be having a mature eggs, we take them out under anesthesia. So it's a small procedure, maybe of 10 minutes, where a short general anesthesia is given, and under transvaginal sonography. So there are no cuts on the body, and all the follicles which are containing these eggs are taken out, and these follicular fluid is taken in the lab. Then the embryologist takes out the eggs, and then he or she does the fertilization of these gamete outside, and then they grow them sometimes to day 3 or sometimes to day 5, depending upon various factors. And when the embryos, either you transfer fresh or you freeze out, and then depending upon what is her problem, whether it is endometriosis, whether it's a fibroid, for what you are doing a IVF, then the decision to be taken for a later transfer of these embryos. So IVF as such to tell is a simple procedure, but little bit physical pain of injection, economical pain of money, and emotional turbulence to undergo.
Okay. Dr. Nandita Palshetkar, normally patients with PCOS, land up with IUI or IVF. How do you manage these patients? How do you go about that?
I think we need to understand, sorry. I think we need to understand that PCOS has become very, very common in our country. Nearly 1/3 of the patients have PCOD or PCOS, PCOS as it's generally known. And it's usually an, hormonal imbalance where the woman is not able to produce eggs. So what we do is we try and give her medications to produce eggs. And usually IUI or IVF is tried when the simple treatment of medication fails, and these patients are then subjected to IUI or IVF. Now remember one thing, as has been explained before, the processes, IUI where we just take the semen and put it inside when the egg is rupturing, because we want the semen and the eggs to come together. So the success rate is only 15 to 20% per attempt. So every patient of PCOS, we would try 2 or 3 attempts of IUI. If it does not work, we shift to IVF. IVF, the success rate is 50% per attempt. And actually, these are very good patients, and we've got a very good success rate. IVF has really advanced over the past 30 years that I've been practicing. The success rate, which was 15% when I started 30 years ago, today it's reached 50%. So IVF is a technology for PCOS patients. And what we must remember is that it's a comprehensive approach. It's not only IUI or IVF. We have to see if there are any associated conditions, like Dr. Pai mentioned, fibroids, endometriosis, etc., along with the PCOS. Then lifestyle modifications have to be told to this girl. Her diet, her exercise, stress, I think plays an important role, and all taking care of all this enhances fertility. And the final thing that I really want to mention in PCOS is they have a lot of mental issues, and that is required to be tackled by a therapist. So I think for PCOS patients, pregnancy does occur, and it's a stepwise treatment. We try medications first. If that does not work, an intrauterine insemination, which is a poor man's IVF, I would call it, simpler, less expensive, and easy to do. And otherwise, we go to IVF, which Sunita has described. And remember that it is multiple cycles. 50% get pregnant the first time, but the other 50% require to go in once more. And actually, in 4 cycles, when the patient is good, young, good ovarian reserve, 90% live birth rate is actually there. So these girls need not despair. They should head for higher treatment if required. That is what we feel PCOS patients.
Dr. Rishikesh Bhai, let me bring you back in here though on another aspect. We've heard a lot also about the intraseptal asmic sperm injection. Where is this indicated? In which circumstances, and are there any newer advances in this area as well?
So it's a tongue twister for you, obviously, the intracytoplasmic sperm injection. So in patients with male factor infertility, poor count or poor motility or morphology, in these patients, the standard IVF doesn't work. Means normally in IVF, we mix the egg and the sperm fertilize the egg on their own. But in these patients with sperm factor, you have to assist the fertilization. So we have a machine, like a semi-robotic machine. So it's called a micromanipulator. You pick up the sperm, immobilize the sperm, pick it up and inject it directly into the egg. So this has been a big breakthrough since 1995. All of us have been doing this procedure, and the results are very good now with the ICSI. So much so that even you can take out the sperm in patients with azoospermia, that is 0 count. You can take the sperm out of the testes and inject them and achieve pregnancy. And now, of course, newer breakthroughs have come in this area. We have something called intraceptally morphologically selected. So normally in ICSI, that is we have magnification of 200 times, but in IMSI we do 6,600 times magnified image. So we can select better quality sperms, give better quality embryos, especially in patients with recurrent ICSI failures, we can do that. And there's a new breakthrough that has now come in, that's called piezo ICSI. So with vibration, normally we inject mechanically, but now with vibration, we can actually penetrate the oocyte, and that reduces the damage to the oocyte. So these are we have also something called spindle check. You can see the spindle chromosome. Imagine you can see now the chromosome spindle while injecting the egg. So that the damage can be reduced. So a lot of new breakthroughs have been coming in, and male factor has become really easy to treat.
Yes.
Before 95 it was very difficult. Now it is quite easy.
Okay. But Dr. Rishma Pai, nowadays also many women suffer from poor ovarian reserve as well. How are such patients handled?
In fact, poor ovarian reserve has become extremely common and worrisome. Why it is happening, nobody knows. Maybe it is, lifestyle, environmental toxins, early aging of the ovaries, essentially. We all know that with age, especially after the age of 35, the egg quality and quantity will reduce. But now, even in younger girls, like yesterday, I had a 25-year-old girl came with very reduced bleeding during periods. And when we checked her anti-Mullerian hormone, that is a simple blood test to check ovarian reserve, was less than 0.1. So in a young age also we are seeing, and it's very easy to diagnose. So simple blood test, AMH, simple sonography for antral follicle count, you can actually count the egg numbers. The important thing here is awareness, education. If a patient doesn't know anything about ovarian reserve, she can't find out about it. But if she knows, she can at least get a simple blood test done, even at a younger age, and she can know that, okay, I can plan my family later. Because nowadays girls are getting married late, they're having children late. The whole thing has changed. Girls are smoking, their lifestyle is not very nice. So the important thing is to diagnose early with these tests, and then we can suggest lifestyle changes. We can actually give some simple medical therapy like antioxidants. We can give DHEAs. There's some small male hormone needs to be added. Growth hormone can be given. Antioxidants. So all of these help a little bit in improving ovarian reserve. But essentially, we have to be conscious of the, what the patient has gone through. Supposing she's had conditions like endometriosis, endometrioma, ovary has been operated upon for some cyst. These patients will definitely get ovarian damage and early, poor ovarian reserve. So they have to be very conscious. They have to check if they feel that, if a patient has, for example, a cancer, she needs to undergo chemotherapy. Before that, she has to preserve her eggs. So now we have the amazing ability to to freeze eggs. And so if awareness is there, they can freeze the eggs before time. And of course, they can freeze embryos if they are already married. There are also now ovarian rejuvenation techniques. We can use the patient's own blood, create platelet-rich plasma.
Yeah.
And
in fact, I want to get in Dr. Sunita on that aspect. Dr. Sunita Tandulwadkar, on that aspect of ovarian rejuvenation techniques, which are being used, as we were just hearing, to tackle patients with poor ovarian reserve. Just tell us a bit more about this technique.
So thank you for your question. Ovarian regeneration, as the name suggests, the ovaries which are aging, we are trying to regenerate them, reinforce them with the eggs. Is it possible in all the cases? Not necessarily. But there are certain ways by which you can at least try, though these technologies at present, we call it as under research. Initially, we give a medical line of treatment, but it may not be working, just the antioxidants or the oral DHEA tablet. So one can think about using the stem cells. Now, what are these stem cells? These stem cells are your own cells. In the body, they are produced in the bone marrow or in a dental pulp or in a fatty tissue, but they have a capacity to regenerate in any organ we put in. So if we take these bone marrow derived stem cells and we can inject into the ovary, you may think about some primordial follicles, some early stage of eggs which are there in a nascent phase. They may get stimulated and the lady can form it. The simpler version of it is PRP, that is a platelet-rich plasma, where you don't need a special laboratories or a specialized people to prepare that. As for the stem cells, you need a lot of permissions. In PRP, you just take a peripheral blood of a lady and you process that and separate out the platelet-rich plasma. So they have a growth factors and many other factors which will help to stimulate those eggs which may be in a nascent phase, and then a lady can think of producing her own eggs and can become a biological mother. But let me tell you, these are in very early stages. They are research, but those women, they want to have their own eggs. As Rishma was saying, 25-year lady with 0.1 mh, her ovarian volume is good. She can try off stem cells, which may be not with one setting, you will expect the magic. You may need 2 to 3 settings. Thank you.
Yes, Dr. Nandita Palshetkar, though, let's talk about something else that's often, used these days. That's fertility preservation or egg freezing. That's the new big thing these days. How does that work?
Yeah, I think today being, Women's Day, International Women's Day, I think this is the ideal platform to discuss it, because egg freezing is a technology which actually empowers women. It gives an opportunity to the girls to preserve their reproductive options. And, as Rishma and Sunita have said, that the girls go through a lot of trauma when their ovarian reserve falls, they face infertility, and the only option sometimes that we can offer them is egg donation. So if the girls are made aware, I think it's very important that awareness should be created that this is a technology where you can actually freeze your eggs. So what do we do? So there are people who freeze for different reasons. Some of the girls, because they are in their career, they cannot have a child so early, or they're getting educated, they go abroad for education, or they're busy with their education. The other things are, patients of cancer, because in cancer we have therapies which are very toxic and they ruin the ovarian reserve.
Yeah.
So in those patients, then endometriosis, as Rishma has mentioned, the surgery, any kind of surgery on the ovary will damage the ovary. So all those girls can be given a choice of freezing embryos or eggs. And I think this technology is an option for delayed childbearing, because otherwise these girls will have no option to have their own biological child. So this technology which came in 2007. In fact, I had a patient in 2007 who came to me once we got this technology of vitrification.
Right.
And she got 3 children out of her frozen eggs. And the earlier patient who had come earlier got only 1 child out of 10 eggs. So, that difference this technology makes, and it is so good, and it is totally available now. Facebook, Apple, all these people are offering their, employees so that they can work without worrying about the biological clock ticking.
True. Dr. Jaydeep Tank, also pre-implantation, genetic testing. Now, this is something that's widely being used effectively for couples who already have 1 child, though with a genetic disorder. Tell us a bit more about this testing, because it's something that one has heard of but doesn't know too much about.
Thank you. In fact, I'm delighted that you specified previous genetic abnormality, because there's a misconception that PGT or pre-gestational diagnosis, as it is called, can be used uniformly for everybody. It shouldn't be. It is specifically, as of now, in clinical practice, meant to be used for couples who have had a previous abnormality in a child which is attributed to genetic reasons. There are, the pre-gestational testing is actually an umbrella term, and it has 3 types of testing. There is what we call PGA, which is testing for what are known as aneuploidies. Then there is the testing for chromosomal structural rearrangement, what is called PGT-SR, and then there is a testing for monogenic disease, what is known as PGT-M. The way this is done essentially is that you create the embryo in the lab, and then you biopsy the embryo. That means you take out 3 or 5 cells from that embryo. These cells are not the cells which will later on go on to form the pregnancy or the child. So these are not those cells. So the biopsy has no effect on future development. These cells are then sent to the laboratory for an analysis. While the cells are being analyzed, the embryos which have been biopsied are then frozen. You don't transfer them at the same time because it takes time to get the results back. And once you go to the lab, there is something known as NGS, or next generation sequencing, which has now come to such a level that you can not only identify abnormalities, but you can also identify what previously couldn't, which are known as mosaics. There is, of course, this whole issue of doing a cell biopsy and so on. And I must tell you that there's some very exciting news coming out of the research world, where we will eventually be able to use what are known as metabolomics, or metabolic byproducts of the embryo, to start screening for these kind of abnormalities. And that's an extraordinarily advanced leap for science, because it will mean that we will be able to get the results faster in a more accurate way without biopsying the embryo and worrying about the consequences of the biopsy on whether the embryo will survive or not. There is a lot to be said for this, but I think I'll stop here because, this is like really the very, very basics of PGT.
Okay, well, we've pretty much run out of time, but I want to get a closing comment now from everyone on the panel. So, Dr. Rishikesh, let me come to you first. What is your take on giving equitable treatment to couples facing infertility issues? How do we make this accessible to all?
No, I think that for us, our country, we have a lot of, not so well off people, and we have to, so I believe in equity, and we must take care of our poor as well. So they also are having this problem. And I would request our Prime Minister to bring this under Ayushman Bharat, health insurance scheme. And of course, we as gynecologists, all of us are quite good people. Everyone thinks of that we are a commercial, but we are not. We do a lot of free work, and we should do more work at concession rates for these people. So that will help a lot of our people to achieve the wonderful experience of becoming parents.
Yeah,
so,
Dr. Rishma, how do we go about this?
Access is extremely important, and people get worried when they require infertility treatment, thinking it's very expensive. But we have already spoken about the fact that majority of the couples will get pregnant with minimum very inexpensive treatment, ovarian stimulation, intrauterine insemination, which are very inexpensive and accessible to all. It's only IVF, because the injections, etc., are a little more expensive, that treatment gets high. But we personally also have low budget centers as well, where we offer very low cost IVF to patients, as well as, top of the line, tertiary care center care to a patient. So we have the entire spectrum to offer our patients. No patient of ours will go away untreated because they cannot afford it.
Okay, Dr. Nandita, your take?
Yeah, I think they've already mentioned the low cost. Let me go on to a different aspect, which is one of the barriers to equitable care, and that is lack of awareness. I think education and awareness, I think we can focus on that, and a lot of people don't know that yes, you can be treated, all the different problems can be treated. And if we have centers even in government hospitals and private medical colleges which are offering low budget treatment, and budget chains all over the country. So I think the awareness is really, really important. We need to go into the communities, we need to tell them about it, because it's a social stigma, so we need to drive away this part of it and say that it's a disease which needs to be treated.
Yes. Dr. Jaydeep, your take, sir, on equitable treatment for couples facing infertility issues?
The first thing I want to say, and I'm only going to say three things here, is that is a misconception that infertility treatment equals IVF treatment. In fact, the large majority of infertility couples can be treated without IVF. And if you want to make it equitable, then that's what we should currently focus on at large. The second is, whatever measure we take for equity has to be sustainable. If you are going to rely on altruism, it's not going to be sustainable, because at some point in time, altruism will run out. And lastly, I think the way forward to plug the gap in the resources that are available for infertility treatment in our country is public-private partnerships. However, it's crucial that the public-private partnerships which are established, particularly for a high-tech issue like IVF and the low-tech part of infertility, be completely equitable and not skewed towards any one kind of a sector, either public or private. Create a win-win situation, and I'm sure that equitable access will follow.
All right. To Dr. Sunita, I'll leave the last word to you on how we can go about making this accessible to all.
I think my colleagues have spoken so beautifully on all. I do believe in public-private equity. That will help, and that will bring this IVF center to many medical colleges as well. Nandita mentioned that there are medical colleges, but they are not very many to have the IVF center. So this will help. But at the same time, I want to tell one thing. People or the needy couple have to understand that they are going to infertility specialists to take the treatment. Many a time they exhaust their time and money, both which are valuable, to be with someone who is not expert in infertility. And by the time she lands up to the IVF consultant, they have no choices than to go for higher treatment. Basic treatment by infertility specialists, thinking about your problem and solving your problem, will be more better. And I feel today, if I have a cancer problem, I will go to the oncologist. So it is a specialized branch, and choose a specialized doctor for that. Thank you.
All right. Well, thank you all so much. We've run completely out of time. It's time for a break, but happy Women's Day to all our viewers, of course, who watch this special telecast, and of course, all our guests. Thank you so much for shedding light on this very, very important issue.
For more such videos, subscribe to the NewsX YouTube channel, hit the bell icon.